And 0 represents the idea of very little to no energy, you know, ready to climb into bed and pull the covers over your head. And 10 represents ready to climb a mountain. In fact, here's a mountain to call to mind. My family is part of the Huguenot diaspora, so the French Huguenot diaspora. So I have cousins in South Africa, in Johannesburg, and in fact in Somerset West. And my cousin Clarissa always talks about climbing the mountain. There's a mountain straight behind her. I'm sure those of you who are familiar with Somerset will know that mountain that I'm talking about. So imagine that 10 out of 10 means being ready to climb the mountain. Just type in the chat for me a number that represents your energy right now. You know, how energized you're feeling. Somewhere between 0 and 10. I'm just going to wait and see. Okay. All right. Oh, wow. Oh, Helderberg Mountain. Is that the name of it? Okay. Thank you. Wonderful. All right. So we've got 0, 7, 9.5. We've got a couple of 8s there, 5, a couple of 0s. Okay. So we've quite a range there. Some of you are feeling quite depleted right now. And thank you. 0 since negatives are not available. Some of you are feeling quite depleted. Some of you are on top of things. So wherever you are, I want you to, wherever you are on that scale, I want you to simply, you know, acknowledge that. You don't need to change it. You don't need to do anything different. You don't need to try and get yourself above 0. Recognize where you are, and let's just see what happens over the next hour as we dig into all of this. I'm going to start sharing my screen, Yakira. It takes just a moment to. Oh, now I've just got a message saying that screen sharing is disabled for me. So something might need to happen at your end to fix that. And as soon
Hi, sorry about that. Try again.
That's all right. There we go. Done. Wonderful. Thank you. All right. So just let me do this. And I'm going to do this, and you should now have a really nice view of the screen from there. So let's begin, shall we? So we're talking about managing ambivalence in behavioural change. Very, very common experience for patients, of course. I'm going to spend a little bit of time talking about a couple of general principles associated with this. Then I'm going to show you a model of change, which you probably have some familiarity with, but I want to use it particularly to touch on how we can respond to ambivalence. And then we're going to finish with a couple of general principles of health behaviour change. Bit of time for questions at the end. If you have questions as we're going, please feel free to type them in the chat. If there's a question that leaps into your mind related to something that I'm saying, please feel free to type it in the chat, and I'll endeavour to respond straight away. You know, while it's kind of in your mind and really useful. So let's start with understanding behavioural change generally. We often, in healthcare, and in fact in lots of fields, we often oversimplify the process of behavioural change. We often think that behavioural change is simply the result of deciding to do something different. I decide to do something different, then I do it. That's it. But in fact, it's much more complex than that. And our behaviours, which you can see in the blue circle up the top there, fit inside this kind of network or cycle of a number of different elements of ourselves. Our behaviours, what we do is connected to what we think, and that includes what we think about ourselves, what we think about what we're going to do. It's connected to our feelings, what we're feeling moment to moment. How many of you have had the experience of thinking, I really should do some exercise, feeling I'm really tired, and then not doing anything different from what you're currently doing? So there's the link straight away between thoughts, feelings, and behaviours. But we also have these two other factors that you see along the bottom there, which are very, very important: beliefs and attitudes. So the beliefs that I have are what I think is true about me or about the world, and the attitudes I have are really the values that I have. What matters to me. So beliefs, what I think is true. Attitudes, what matters to me in life. All of those things together interact in this reasonably complex and chaotic way to determine what we ultimately do in our day-to-day lives, the behaviours that we exhibit, and they all influence each other. Of course, if you perform a particular action, if you're engaging in behavioural change of some sort, if you're trying to increase the amount of exercise that you do, for example, if you feel like you've been successful there, that's going to have an immediate impact on how you feel. Probably going to feel good. It's going to have an impact on what you think. It's going to have an impact on the beliefs you have about yourself. I can do this. And then the next week, when you go to work and you have to run up a flight of stairs and you feel like you do that more easily than usual, that's going to influence your attitudes as well. It's going to make you more likely to feel like, you know what, this exercise is really worthwhile. It's really valuable. I can see the benefit of it in my daily life. So the first thing I want to do is make sure that we position behavioural change inside this fairly complex network of other factors that influence what we do. We said we were going to talk about ambivalence. So ambivalence, of course, comes from two Latin words, which literally mean both, that's the ambi part, both have value, that's the valence part. So in other words, I'm faced with a situation in which both of the choices that I'm faced with feel like they matter to me. They feel like I want to engage in them. And ambivalence, of course, in all of our lives is completely normal. It's not just a factor that emerges in behavioural change discussions or health behaviour change discussions. If you're someone who likes to eat out at restaurants and you open up a menu and you can't decide between this or that on the menu, that's ambivalence. If you decide that you're going to go out for a night with your family and then your good friends say, come over to our house for dinner, and you're now not certain which to choose, that's ambivalence. We're all faced with these situations all the time. So the first thing to recognise, of course, is not to be afraid of ambivalence, and certainly not to be afraid of ambivalence in patients. My experience in talking to physicians and other healthcare professionals is that they often feel like they need to convince the patient of which path to take, that the ambivalence must be resolved as quickly as possible. And I want to suggest to you that nothing could be further from the truth. And in fact, that drive to try and fix the ambivalence is often what leads people feeling a little bit stuck. And I'm going to show you why that is in just a moment. So tip number one, don't be fearful of ambivalence. In fact, I'm even going to use the word embrace. Embrace the ambivalence that your client is experiencing. One of the ways of thinking about ambivalence from an appreciative perspective, of course, is the idea that if someone's feeling ambivalent about doing something, it means they've actually got enough energy to get interested and invested in not one thing, but in two different things in their life. And that's good. If someone has that amount of energy, then that's something that we can harness. I would much rather work with someone who is expressing ambivalence about change than someone who is expressing zero interest in change, because the ambivalence represents a bit of unharnessed energy. Sometimes we can inadvertently exacerbate that situation. And that arises sometimes through a mistaken belief that clinician-patient interactions are linear. If I tell my patient something, they will know something, or if I encourage or instruct my patient, they will do something. In other words, it's a unidirectional, a one-directional transaction where the force is here and the outcome is there. In fact, just like all human relationships, clinician-patient interactions are circular. And so what we often see in practice is someone expressing ambivalence, the patient, B, expressing ambivalence, and the clinician responding to that by trying to convince the patient that they really ought to follow this pathway because this is the better pathway. So, for example, imagine you have a patient who, might want to reduce their alcohol consumption, for example. But the context in which they drink alcohol is when they go out with friends on a Friday night. And their dilemma is, if I don't drink alcohol, I'm going to feel awkward around my friends and I might want to go out less. And if I go out less, then I'm going to miss the social contact. Now, we all know that social contact is really important. So now your patient has a dilemma. A lot of physicians will respond by saying, yes, I hear what you're saying, but you know it's really important to cut back on alcohol, don't you? So trying to urge the patient down that pathway. The patient, of course, in that moment has an experience of feeling like, I haven't actually been heard. You haven't understood how difficult this is for me. So what do they do in response? Well, often they'll start to argue back. Yes, I know it's important, but my friends really matter to me. I really want to spend time with my friends. And when the clinician hears that, the clinician's anxiety spikes. Oh no, the patient's digging in even harder. So what do I have to do? I have to work even harder to convince them. And you can see very quickly this develops into a really tightly wound circular interaction where the clinician's working very hard to convince the patient of one thing, and the patient is working very hard to convince the clinician that this story is much more complex than they think it is. So that's the trap or the pitfall that we can fall into fairly easily. And that's one of the things that can perpetuate ambivalence in a patient. That all stems, of course, from our own anxiety as clinicians with ambivalence. If we're able to say, well, the person's in two minds about it, I'm okay about that, let's find some ways of exploring it, then you're much more likely to respond in a helpful way. And I'm going to start showing you some of those helpful ways very shortly. What's going on? There we go. There we go. So just give me maybe a letter Y for yes in the chat if you are familiar with the trans theoretical model of change. It's a very common model of change. It's been around for a number of years. Yes, number of you saying yes. Wonderful, wonderful. It's several people, of course, have developed the ideas, but James Prochaska and De Clementi were the originators, really, of this model. As the name suggests, it's not. It attempts to describe change in a way that can be applicable to a number of theories of behavioural change. By the way, while we're talking about theories of behavioural change, I wonder if anyone knows how many distinct theories of behavioural change there are and how many have been described in the literature. If you think you know the answer, type a number in the chat for me. This is a lot of fun, this question. Let's see what comes up here. How many distinct theories of behavioural change are there? Anyone want to have a guess here? 10. Okay, we've got to vote for 10. 10 would be a lot, wouldn't it? 10 different theories to explain behavioural change. That would be a lot. Well, let me tell you a funny story. In 2014, some researchers at University College London published a scoping review in, I think in the journal Health Psychology Review. They published a scoping review of theories of behavioural change. In the introduction to this paper, they described the 82 theories that they reviewed for this scoping review. 82 different theories of behavioural change, which is, I think, rather extraordinary. The really funny thing is that when you reach the conclusion of this paper, the conclusion says, so in the preceding 83 theories that we've reviewed, which of course suggests very strongly that in the time it took them to co-write this paper together, co-author this paper, someone came up with another theory of behavioural change, increasing from 82 to 83. The world is awash with theories of behavioural change, and they all, they all have benefits, they all have shortcomings, they all tend to look from a slightly different perspective. The trans-theoretical model of change endeavours to kind of be if you like, a bit of a meta theory to sit over the top of them. But it starts with this idea that someone is not even considering making a change. It's pre-contemplation that you see outside the circle. And that can be either because the person doesn't feel like they can want to change, doesn't feel like they can change, or doesn't feel like they want to change, one of the two. The person then in this model moves into a stage of contemplation, considering it. Maybe I will, maybe I can. And then, if sufficient milestones are passed, then they might decide to start preparing for the change. I think I will do this. I think I will engage in this change. If they keep going down the pathway, they reach the action stage. I am doing this now. I'm starting to do things differently from what I used to do. If they keep doing that, then they reach the maintenance stage of change. And these are, when we talk about maintenance, we're talking about really strongly embedded long-term habits of behavioural change that people have been engaged in for a long time. In this model, people can lapse in other words, to fall back to an earlier stage of change, or if they do it more than once, they can relapse as well. And one of the nice things about this model, of course, being a circular model, is that if someone lapses, well, we just pick up where they are and look at ways of moving forward again. So a lapse or a relapse in this model of change is not a serious problem, really. It's something that we can address within the model. Ultimately, if someone is successful at embedding a behavioural change permanently in their life, then they more or less exit this model, as you can see over there on the right. So it's a really useful model, really useful way of thinking about behavioural change. One of the things I particularly appreciate about it is that regardless of where you are, it provides a way of us as clinicians being able to relate to and respond to our patients, to support them wherever they happen to be. It's also a way of removing judgment and evaluation from people's progress. We can simply acknowledge they are where they are. And they're doing what they're doing. No one stage is better than another stage in this model. This is not a model that says it's more desirable to be in the action stage than the preparation stage. It's simply a model that says some people are here, some people are there, and they can move. So tremendously useful model, and lovely to see that some of you are familiar with it. If you're not, then I'm going to encourage you to find out some more about it. We're going to find out some more right now, and I'm going to walk you through these stages and show you some ways that in clinical practice you can respond to your patients in ways that are going to support them to feel like you understand their experience and will support them potentially to keep moving down this pathway. So over there on the left, you can see pre-contemplation. If someone's at this stage of change, what it really means is they're saying either I won't make a change. In other words, yes, people are telling me people tell me I should give up smoking, or people tell me I should stop drinking. I'm 65 years old. Look at me. I'm as fit as a bull. It's not hurting me. I've got no intention of changing. So that's the very clear I won't. Other people might have a perspective of simply lacking knowledge, lacking skills, being uncertain about what to do. I can't change. I've tried so many times to lose weight. It works for a while, and then I just end up back where I was, and it gets harder and harder every time, and I get tighter and tighter. of trying to do it. I just don't think I can do it anymore. So that's the other side of pre-contemplation. What's the best way to respond in clinical practice? Number one, show that you understand. That's the empathy that you see there. Show that you understand. I hear how challenging this is for you. I hear how difficult this is for you. It's really clear that you enjoy what you're doing at the moment. In other words, reflect that current desire. Now, this is a little bit counterintuitive because clinicians sometimes think, if I reflect that in that way, if I say to my patient, well, it's really clear that you're enjoying doing this, isn't that just going to reinforce what they're currently doing? I'm going to suggest to you that your patients do not need your reinforcement to continue that behaviour. They're already strongly enough invested in it that they will do it anyway. So what this does do when you display empathy, when you show an understanding, it now pushes you to the number one position in your patient's mind of people who understand me. And if I ever reach a point where I do want to make a change, who am I going to talk to? I'm going to talk to the person who I feel understands me the most. So this is the very best thing you can do for someone who's in the pre-contemplation stage. Make no effort at all to change them. By all means, offer some educational resources if they would like it. Ask them first, would you like me to share something with you? Offer that if they would like it. Be curious about what they do want, not what they don't want. If the person says, I've got no intention of giving up smoking, fine. Well, what area of your health would you like to focus on? What would be of interest to you? We'll turn the conversation there, and beyond that, simply reflect where they are. Show that you've heard and understood. Make yourself the person to whom this patient will return when they really do want to make a change. Make yourself different from other people that they might have encountered in their journey. So that's pre-contemplation. Contemplation, of course, is the idea where, or is the stage, if you like, where patients begin to express the possibility of change. Maybe I will. I might do that. I'll consider that. Maybe I could. Maybe I can. Yeah, it's not a bad idea. I'll think about it some more. What sorts of things as a clinician can you do there? Well, again, empathy. Show you understand. Show you've heard the patient, show that you've heard the concerns they have, the worries that they have, the dilemmas that they're experiencing. A little like that dilemma I shared with you before. I really want to give up alcohol, but I only drink on Friday nights with my friends. So I don't know, if I stop drinking, then I'm worried I won't enjoy the time with my friends anymore. Reflect that dilemma without judgment. So what I'm hearing in what you're saying is that looking after your health by giving up alcohol and spending time with your friends are both really, really important things to you. Notice how neutral that is. I'm reflecting both parts of that in a really neutral way. I'm not saying, so I know you want to spend time with your friends, but if you keep drinking at this rate, that's going to damage your health. That's a kind of an uneven reflection. And I'm starting to slip into urging someone to make a change rather than reflecting the dilemma without judgment. The skill or the set of skills of motivational interviewing, which is a particular technique that can be used to support people who are feeling ambivalent about change, describes a process called decisional balance. Decisional balance is really, really useful, and it's a means of supporting your patient to walk through both the benefits and the disadvantages of both staying as they are and making a change. So again, you can see how even-handed it is. Benefits and disadvantages of both sides of the equation, both staying as you are and making a change. Decisional balance is not intended as a convincing tool. It's not a means of getting someone to change their behaviour. It's simply a means of exploring the dilemma in more detail so that your patient has more clarity, and so they're in a better, more informed position to be able to make a decision about what they might do. And the other really important thing to do when someone's in this contemplation stage is express your own confidence as a practitioner in them. This is where we want the confidence to be. We want our patients to, over time, develop this confidence in their capacity to make a change. We don't want them to be perpetually dependent upon us for advice or encouragement or urging or direction. So reflect the dilemma in that non-evaluative kind of way. Use the decisional balance tool if that's helpful, and at the conclusion of that, simply say to your patient, you know, it's all of these elements seem very, very clear to me now, and I imagine they are to you as well. I'm really confident that, given some time, you'll make the right decision for you. And that's a powerful prompt or cue for your patient, for you to express confidence in them. If someone's in the preparation stage of change, sometimes they're still carrying a little bit of ambivalence with them. They're still not really certain about the process of making a change, but they are moving more steadily towards the idea of an intention to change. So we can summarize this by saying, I will. The person is now saying to themselves, yeah, I feel like I think I'm going to do this. I think I'm going to do this. I think this will be good for me to do. Because they can still be carrying some ambivalence, but because they've moved just a little bit from that contemplation stage, it can be really useful to amplify that small progress they've made. This is a bit like magnifying under a microscope. When I use the word amplify here, it's like spending much more time and much more focus on this process that they went through. How did you get to this point? How did you decide this? What made this important enough for you to shift from, I'm not sure, to, I think I will? And spending time there is really valuable because it unpacks or deconstructs, if you like, with the patient, this process that they went through to get there. And as they understand that more deeply, they're much more likely to become committed to those ideas that are important to them. Be curious with your patient about what's next, and what might need to be in place now that they're thinking they'll do this. Now, one of the analogies that lends itself fairly easily here is the idea of, say, building a house. If someone is saying initially, I'm not sure, I don't think I want to build a house, or I'm not sure I can afford to build a house. A good builder doesn't try and strong arm the person into building the house. They simply say, okay, I hear you. I hear that you don't have enough money, or you're not sure if you want to do this. You know where to find me. This is what I can do. If it's useful to you at some stage, I'm happy to help you. Then when that person reaches the stage of contemplation, they're saying, well, maybe I will build a house. Maybe I'll do this. Builder's going to respond by saying, wonderful. Well, let's talk some more about that. How have you got this far? What are you thinking might be the benefits and disadvantages of building a house versus what you're doing right now? When the person gets to this stage of saying, you know what, I think I really do want to do this, then the good builder is going to say, wonderful. Well, tell me, how did you arrive at this decision? How did you land here? What made it important enough for you to decide that you want to build a house? And what can I help with now? What can I do? What else do you need to be in place for you to feel like you're going to be able to take a step forward here? This is when it's really important to support your patient to link up their decision. So this decision that's shifted the needle for them just a little bit back to their values or attitudes that we talked about earlier on this evening. Help them to see the link between what really matters to them and what they're deciding to do right now. It's a little early to start setting behavioural goals with someone if they're in the preparation stage, but thinking goals can be really useful, or planning goals can be really useful. So, for example, encouraging your client to spend time reflecting on what needs to be in place, or what else needs to be in place to support them to make another step forward. Encouraging them to continue thinking about the relative benefits and disadvantages of, moving forward with this or not moving forward with this. Encouraging your client to spend time in reflection and self-reflection can be a really, really useful strategy here. One of the goals that I like to use fairly often at this stage of change is simply an observational goal. So, for example, if my patient is saying, "Well, yeah, I'm thinking, I'm starting to think, maybe I'm going to do this," and I get a sense that the ambivalence is still fairly strong here, I'll often respond by saying, could I ask you to do something between now and next time we meet? What I would love you to do is to simply notice the times when the feeling about changing is stronger in you. That's it. Notice the times when the feeling about changing is stronger in you. And that task, or that activity, draws your patient's attention, of course, to what they're actually experiencing when they're thinking about behavioural change. And that also can have that amplifying effect that we're seeing at the top of the screen there as well. So that can be a really helpful response at that time. If you're fortunate enough to have been able to support one of your patients through this, and they're now ready to make a change, they're in the action stage, raring to go. This is where they're saying, "I am doing this. I'm committed. I've stepped over the line, and I want to make a start." This is where goal setting is really important. SMART goals are useful. I'm sure you're familiar with SMART goals. The SMART framework: specific, measurable, actionable meaning right now, relevant meaning related to the person's attitudes and values, and time specific, measurable, actionable, relevant, time specific. A lovely framework, particularly for people who are new to goals. It's not the only framework for goal setting, though, and there are other frameworks that simply suggest things like have a challenging goal that can be broken down into small steps, and that can work very well. And that's the Locke and Latham theory that you can see I've got on the screen there. Locke and Latham talk about the importance of clarity of the goal, so it's clear enough for your patient to understand. It's challenging enough for them. They have sufficient autonomy or choice in this. The goal is complex enough to result in a behavioural change. And finally, that you encourage your patient to reflect on their learning from what they've done. Learning, of course, is a very important part of goal setting and working towards goals. The idea of learning is embedded in things like social cognitive theory, social learning theory as well, self-efficacy theory. It's the process through which we take lessons from what we've done and apply it to things that we're going to do. And of course, the other really important focus here is incremental progress, small steps. It can be a little tempting, if your client has made a change and you've been working with them for quite some time to support them to make this change, it can be a little tempting to try and grab hold of something big and audacious, big and bold as a behavioural change. And there can be some dangers in that because it may mean that that it's too big a bite too soon. So incremental progress is fine. There's I believe it's a Chinese proverb that says, "A journey of 1,000 miles begins with a single step," and that's a really useful idea to keep in mind. And if your patient reaches the maintenance stage, this means that they are still doing this behaviour. They've really embedded it into their daily lives. It's kind of become a part of who they are. So whether that's exercise or a change in diet, or they've got some stress management tools now that are really effective for them, or they've uncovered tools for managing, relational conflicts that they might be having. Whatever those tools are, they're putting them into play regularly in their lives, and they're seeing the benefits of it. So the best clinician response then is to support your patient, to acknowledge the progress they've made, to celebrate where they've got to see that connection again between what they're doing now and what they wanted to do. You can, if you wish, depending on what your patient wants, revise what they're working towards. Maybe now that they're doing this, they want to modify it slightly. Maybe they want to do something a little bigger, a little bolder. And if that's the case, go for it. Set new goals, make new challenges. And one of my favourite tasks to do at this point is encourage your patient to give back. Encourage them to think about the role that they may be able to play in supporting someone else who's facing a challenge or a difficulty, someone else who needs to make a change. If your patient is a parent, encouraging them to think about ways in which they can role model to their children, how they can support and encourage their own children in these ways. There are lots of really lovely things that you can do to support your client or your patient to stay on this path that they're on once they've got there. Lapse and relapse. I'm just going to spend a little bit of time here. It is important to recognise that people can slip back and fall away from a robust behavioural change that they were engaged in. If they have that experience of "I slipped," most important thing to do is display empathy, not sympathy. "Oh, I'm so sorry. Oh, I'm so sorry to hear that. Oh, that's terrible." That's sympathy, or sometimes even pity. So we're going to put sympathy and pity, put them over there, and instead we want to display empathy, show that you understand. Okay, so you're telling me that things were going really well, and last week you found yourself drinking again. Okay, and I can hear how disappointed you are with that outcome. So that has a qualitative difference to "oh, you poor thing," or "oh, that's terrible," or "oh, never mind, you can get back on the horse," or something like that. It's really valuable if your patient slips. It's really valuable to focus on what you've learned in this process. What can you take away from this? How can you make this slip useful to yourself by extracting some learning from it that you can now reapply as you move forwards? That slip or that lapse or relapse is often back to a place of ambivalence for the patient as well. They often, if they've started engaging in a change and they have a slip or a lapse, they often find themselves again saying, I'm not sure if I can do this, or I'm not sure if I want to do this. I really, I had a scoop of, I don't know, mango ice cream, and I remembered how much I loved it, and I don't know that I want to give it up. So they can find themselves back in that place of ambivalence. What should you do? Well, then you should go back to that stage of the change and respond in those ways that are really helpful for that stage of change. So one of the takeaways I want you to think about here is the idea that we can have a set of tools that are useful for responding to patient dilemmas across stages of change, and that we can nuance those tools slightly between each stage of change, do slightly different things depending on where the patient is. And it's those nuances in our responses that can really make a difference to patient outcomes. I mentioned decisional balance before. There's a graphical way of representing it. And you can see there that you explore the disadvantages of not changing and the disadvantages of changing, along with the advantages of not changing and the advantages of changing. A simple 2x2 grid I always encourage people to use very neutral language in doing this. Even though as a physician, you may think it's beneficial for your patient to move in a particular direction, do a particular thing. Work hard not to play your own hand, because ultimately we want the patient to play their hand. We want theirs to be the winning hand. We want them to be the ones who put the cards down and say, this is what I'm going to do here. So use this tool in a really neutral kind of way to explore those dilemmas. One of my favourite general approaches to all of this is taking an appreciative approach rather than a teaching or instructing approach. Sometimes patients need some information, but probably a lot less than we think. The world is awash with data. The world is awash with sources of data. And yes, there are absolutely some incorrect sources of data, and there is some unhelpful information that floats around. Yeah, I'm sure you have patients who come to you and talk about something that they've seen on Instagram or TikTok, and they're sure that it's going to revolutionise their health dilemmas. There is absolutely incorrect information, and we should call that out. Be careful not to turn all of your interactions into information-giving interactions with your patient, and instead take an appreciative approach. Be curious about the strengths that your patient has to make changes to their health behaviours. Be curious about a success story that they've had somewhere along the way. Tell me about an area of your health that you've been able to manage well. Find out what worked well. What did they do? What were the values that they drew upon? How were they successful here? What were the strengths that they made use of? Who supported them? Get curious about that journey. Find out what they perceive to be the opportunities right now, and find out what they would really like in relation to their health and well-being. And that alone, that question around what would you like to be different is a really important question. Often patients will begin by saying, I want to lose weight, or I want to get fit, or I want, something like that. The question we should always ask next is, what's making that important to you? How come you want that? Yes, losing 20 kilos might be a useful thing to do, but how come you want that? What do you want to be different in your life? What do you want to be able to do in your life when you've lost 20 kilos that you can't currently do? That question really helps your patient connect up their stated goal or their stated wish to their values. Think of that appreciative approach. There's a question here. Is the OK, SMART is OK also an acronym? I'm not sure that I understand that question. So maybe we can come back to that at the end. SMART is an acronym: specific, measurable, actionable, relevant, time specific. So SMART is an acronym. I'm not sure if that's the answer to that question though. But let's revisit it. Another very important technique in managing ambivalence, and this comes from motivational interviewing as well, is what's called rolling with resistance. So you might be familiar with that idea of resistance in patients. I have a slightly different perspective. I don't think patients are resistance. I think resistance is something that emerges in the clinician-patient relationship, often when the clinician isn't clearly enough understanding the patient's dilemma. If the patient's saying, I really want to cut back on alcohol, and I want to spend time with my friends, and the clinician is saying, okay, but you really should cut back on alcohol, and the patient says, yeah, I know, but I'm really worried that I'm going to, miss out on time with my friends. And then the clinician says, yeah, I know spending time with your friends is important, but if you keep drinking like this, you're not going to have any friends. Then over time, clinicians will often label that patient as resistant. And in fact, what's happened is resistance has emerged as a feature of this relationship because of the interaction between the clinician and the patient. So the motivational interviewing advice is, don't try and correct the person, but connect with the person. Show that you understand. Show that you've heard the dilemma. Show that you appreciate just how difficult a decision this is, and express confidence in your patient to be able to make the right decision for them. So that's a technique from motivational interviewing. One of my favourites, which goes back many years to when I first trained as a family therapist in the 1990s, is this idea of the third option. Often we get caught in this idea of binary. Either I've got to choose this or I've got to choose that. I've got to do this thing or that thing. And people end up putting quite intense pressure on themselves to do this thing or that thing because they manufacture it or they construct it as a binary choice. So one of the ways to resolve that dilemma, of course, is to introduce a third option. And the third option is, what if you were to decide not to decide right now? What if you were to postpone that decision? And that now becomes one of the possibilities in everything that's there. So that's an approach that I often use. If I hear my patient or client starting to kind of get themselves wedged into this binary thinking, I've got to choose this or that, then I'll drop a third option in there as well, just to free that up and change their thinking around that. So some things to keep in mind. Number one, ambivalence is completely normal. We all experience it every day of our lives. We all face moments and times where we feel torn between doing this thing and that thing, or choosing this thing and that thing. Completely normal, not unusual in the slightest. Don't be fearful of it. Remember, the ambivalence belongs to your patient. It's theirs to resolve if they choose. It's not your job to change their mind. It's your job to support them to understand the choices. It's your job to support them to understand the outcomes, the consequences, and so on. It's their job to change if they choose to do that. Remember that urging change, no matter how noble it might sound, almost always leads to the emergence of resistance in the relationship, because simply through that mechanism that I described, your patient feels like you're not hearing and understanding their dilemma enough. So they're just going to keep repeating that dilemma until they feel like you understand it. And once you show that you've understood it, guess what's going to happen to that resistance? It will literally dissolve. And for your own health and well-being as clinicians, don't cycle harder or faster than your patient. Don't do more work than they're doing to resolve this. Focus by all means on supporting them to make a change, but remember that the change is theirs to make, not yours to make. The analogy that I often think about here is the analogy of a tandem bicycle. Now, if you could ride a tandem bicycle with someone, let's use the letters F for front and B for back. Which seat would you choose, F or B, if you could ride a tandem bicycle with someone? What would you choose? Let's see what the poll is here. Interesting. F. Lots of people want the front seat. F. There's a vote for the back seat, Ruben. Thank you. So I'll tell you what, if I've got a choice, I'm choosing the back seat. You know why I choose the back seat? I want to see how hard you're working. And I'm not going to work any harder than you are. So I want to be able to see what you're doing so that I can adjust my own effort accordingly. So there we go. And I'll finish with a little poem for you. This is possibly my favourite poem in the world, actually. It's written by a Danish gentleman named Piet Hein, H-E-I-N. He's now deceased. He was an absolute genius. He was a mathematician. He was an English scholar. He was a Danish scholar. He was a poet, a philosopher, and historian. And he's written a lot of poems, which he calls grooks, Grooks. The books are quite hard to get now, but they're a lot of fun. But his my favourite poem of his goes like this: whenever you're called on to make up your mind and you're troubled by not having any, the way to solve the dilemma you'll find is simply by tossing a penny. Not so that chance shall decide the affair while you're passively standing there moping, but as soon as that coin is up in the air, you suddenly know what you're hoping. It's a lovely poem that speaks to the importance of connecting to our values, the importance of understanding what we really want before starting to engage in a behavioural change. And for me, that's one of the most important roles that a physician can play, supporting patients to understand why they want to make this change, helping them to say that out loud and uncover that as part of the process of working with them. Well, there we go. Let's stop there, shall we, Yakira? I'm very happy to, if people would like to ask questions, very happy to do that. People would like to type some questions in the chat. I'm happy to do that as well. I'm going to place myself in your hands here, Yakira, and let you take it over for a while.
Thank you, Simon, so much. There was just so much brilliant information, but I definitely liked your analogy of the tandem bike. I can barely ride a bike, but I learned last year as an adult in Amsterdam, because I was like, either I learned to ride or I'm not going anywhere. But I think it speaks to a very big truth that, you know, very often that is us. You know, we're trying so hard to push our patients to change, and you're not getting anywhere. Like, they really need to do it with you, or they're going to fall off. Like, if you're cycling much faster, they can't keep up. They give up and fall off.
Yeah,
that's really
that can happen too. Exactly right. Yeah.
Yeah. Sorry, I asked actually. So basically, you said SMART is okay. So I'm very familiar with the SMART framework. I wanted to know if okay, because it was also in capitals, if you meant it as like the word okay, or if that stood for something.
Oh, no, sorry. My apologies for that confusion. No, okay is not an acronym. No, I was just using the word okay as in, you know, smart's an okay framework if you want to use it.
Okay.
And there's also some other ideas as well. But you know, smart does the job. Smart does the job, particularly for people early on in the process of behavioural change.
Yeah, I find a lot of people find it really easy, and you can almost give them a template that they can fill out, which I do with my patients. And I think it is simple. It's like really specific, which helps.
Yeah.
So please, everyone, we have a question. The video gets uploaded to our website, which is free for all our members. For non-members to access the video, you pay for the CPD accreditation, and it's 150 Rand. Alternatively, feel free to join our membership. It's 800 Rand for another 2 days, and then it goes up. But really and truly, we upload every month different webinars on different topics.
Wonderful.
Jeanette, thank you.
There's a couple of questions, Yakira, in the chat there. Someone's commented that this process of coaching needs lots of practice. Absolutely, as all things do. You know, and the more that you practice it, the more effective it becomes. And I'm also going to say here, coaching is not rocket science. It's not, you know, it's not. It's really the skills of understanding the process of change and matching language to that. So yes, absolutely, it requires practice, and absolutely it requires some learning. And the more that you do that, the more effective you will find that becomes. Yeah, absolutely. Yakira, I would love if people who are here, maybe you could just type one thing in the chat that represents a bit of a takeaway for you from this evening. Just something that's, you know, perhaps stuck with you a little bit, or something that stood out to you. Anything at all that you might want to share. Just drop a word or two in the chat. While we're talking about that, Yakira, and Lydia, I'm not sure whether you're still here. I a while ago, several years ago, wrote a tool called the Quick Intervention for Change. Lydia, I can't remember whether I've shared that with you or not. If I have, wonderful. If I haven't, tell me, and I'm very happy to share it with you. It's a tool that I developed for physicians, absolutely free to use, and I'm very happy to circulate it amongst your membership. Oh, I have. Good. Okay. Wonderful. Thanks, Lydia. I appreciate that. Yakira, yeah, thanks. Great takeaway, helping patients to find their why. So yeah, just to reiterate that that quick tool is on the Salma website, so you can. I'm not sure exactly where, but I'm sure it's locatable. If you can't find it, email me and I will send you a copy myself. So very happy to do that. It's under resources. Thanks, Yakira.
Simon, thank you so much for your time. Honestly, you're an extremely busy person. Oh, and Jeanette, yes, that's a beautiful one. I really
Ambivalence is good, yeah. Lovely perspective, Jeanette. I love that. Ambivalence is good. Yes, it is. Ambivalence means that your patient, it actually has some energy, not just for one thing. They have energy for two things, and I love working with people who have some energy to do something. Yeah, wonderful, wonderful takeaway there about empathizing, not sympathizing. Yeah, just acknowledging, acknowledging the challenge, acknowledging the obstruction, acknowledging the slip and fall, and saying, well, okay, here we are where we are. What can you say you've learned? What can we do now? Onward and upward. Yeah, wonderful. There's another wonderful. I often talk about the impact of force, fact, and fear. Three tools that are often used to try and urge change, and they certainly work in the short term. Thank you for that. Thank you for that comment. I appreciate that. That's lovely. Look, force, fact, and fear work in the short term to bring about behavioural change. We all know this because if we're speeding down the highway and you see a car up ahead with some red and blue flashing lights, what do? Well, you slow down. And what do you do when you've driven around the bend in the highway and that car's out of sight again? You speed up again. So it changed your behaviour in the short term, but not in the long term. So force, fact, and fear, are not great for sustainable behavioural change. Oh, lovely, Lydia. Thank you. I'm glad you like that. It's a wonderful poem. Yeah.
I just want to say, you said something earlier about ambivalence and the patient has space for two, but as you taught us, they have space for three options, and kind of giving them that loophole to say, let's come back to this, I think is pretty powerful.
Exactly right. Exactly right. And if your patient really feels stuck, then the question around, well, what other areas of your health are important to you right now? So in other words, let's not, you're feeling a little bit stuck here. Let's not perseverate on whether you're going to, cut back on alcohol or not, or whether you're going to exercise or not. What else in your health matters to you? Where else could we turn our attention? Be curious about everything that could be there to get some movement somewhere. Rather than,
not all or nothing thinking.
Exactly right. Yeah, and that all, in my experience, that all or nothing thinking, or sometimes what we call boom and bust thinking, is very, very common in chronic disease patients because that's been the experience of their lives. Often for many decades, they feel like, I've had a little bit of success and then I went backwards. I got on this diet and then it failed. I got on that diet and then I failed. I went to the gym for a while and then I put the weight back on. So their whole sense of themselves is binary, boom, bust, boom, bust, boom, bust. So the sooner that we can start to engage in a different narrative that's not binary, doesn't just focus on the idea of either this or that, then the more likely we are to be able to support them to start learning some things, appreciating some things, and engaging in other changes.
Simon, thank you so much. Honestly, every time you talk, I'm just like, this is brilliant. And you gave examples, and I think it was just the most powerful talk that many of us needed, especially at this time of the year when you start to hit the end of March and you, I think even as individuals, that New Year's resolution joy and new start effect fades, and then we start hitting that March, April slump. And I think these some really powerful tools that we can all take with us from today. I want to thank you again on behalf of Selma for your time. You're an extremely busy person, and
my pleasure. My pleasure. Absolute delight to be here.
Thank you so much. And thank you to everyone for joining us, literally from all around the world. Really, that was really powerful. As I said, we do host webinars every month, so stay tuned for our next month's one, which is going to be on childhood obesity. So something different, but still really, really important. And just Simon, thank you so much again from all of us for taking the time to teach us so much today. Have a lovely day, everyone. Happy Easter.
Thank you, folks.
And we look forward to seeing you soon. Thank you.
Lovely to have been here. Thanks, everyone. Good night.